Good evening, colleagues. Today we are in for a cardiology summit. All of us know that the cardiovascular disease is becoming rampant in our society. Probably there are so many reasons are attributed to that, yet it is still ranks highest. To talk about some of the aspects of cardiovascular diseases and its treatment, we have got with us two eminent speakers. The first topic will be Management of Acute Coronary Syndrome 2025 update. You know that everything cardiology is one field where newer trends are coming every day, and it will be interesting to hear from Dr. Sandeep, consultant cardiologist, Astra Medicity, to talk about management of acute coronary syndrome. Sandeep, his academic qualifications goes like a Mahabharat. Dr. Sandeep is an empathetic cardiologist. After completing his undergraduate from Raja Muttaya Medical College in Tamil Nadu, Dr. Sandeep went to pursue his MD Internal Medicine from Patil Medical College, Bijapur, Karnataka. With special interest in heart health, he further completed his DM Cardiology from Government Medical College, Calicut in 2015. He also completed his DNB Cardiology in 2015. Since then, he has been practicing as an independent consultant cardiologist in various hospitals, including Rajagiri Hospital, Marsleva Medicity Hospital. His areas of interest are in primary and elective coronary interventions, heart failure management, and cardiac imaging. At the moment, he is working in Astra Medicity. Over to Dr. Sandeep.
So, good evening, everybody. Thank you for this invitation, and it's a pleasure standing here and presenting. So, this is the latest update, 2025 ACC update regarding the guidelines of management of acute coronary syndrome. The difference of this update is that it has combined both ST elevation myocardial infarction guidelines and NSTEMI guidelines into a single one. So, first of all, as you all know, what is an acute coronary syndrome? So, any sudden blockage of the coronary vessels causing ischemia comes under acute coronary syndrome, which can present in three ways. Either it can be an occlusive thrombus producing ST elevation, and it's called an ST elevation myocardial infarction, or a non-occlusive thrombus producing either a biomarker negative, when it's called unstable angina, or a troponin positive, then it's a non-ST elevation myocardial infarction. So, normally, how do we diagnose ACS? As I'm sure you all will be knowing, it's mainly from the history. If any patient comes with a new onset of chest discomfort, or a worsening chest discomfort, or a rest angina, then we should suspect this patient is having an acute coronary syndrome. So when he comes to the clinic or a hospital, the first thing to be done is get an ECG done. So the criteria is that it should be done within 10 minutes. So the faster the diagnosis, faster the treatment. So if you take the ECG within 10 minutes, and if the ECG shows an ST elevation myocardial infarction, then this patient is a candidate for reperfusion therapy, which can be either a fibrinolysis or a primary PCI. But if the ECG is normal, it is not showing ST changes, or if it is showing ST depression, TVA inversion, anything else other than ST elevation, then the next thing to be done is you have to send a troponin also. If the troponin is positive, then this patient comes under non-ST elevation ACS, or if the troponin is negative, then he comes under an unstable angina. So once these patients are admitted, then we can use either the certain risk scores which has been recommended. One is the Grace risk score or the Cme risk score. So this will help us in stratifying the patients into high risk, intermediate risk, or a low risk. So any patient who comes with acute coronary syndrome based on the symptom, the first thing to be done is a 12-lead ECG. It should be done within 10 minutes. And then if the first ECG is not showing any changes, but the patient continues to have chest pain or any worsening symptoms, then a serial ECG has to be done every 10 to 15 minutes, so that to find out if these patients are going into an ST elevation myocardial infarction. So the importance of timing is that with every 30-minute delay, there is an associated increase in 7.5% relative risk of 1-year death. So the guideline mainly focuses basically on this time, that is ECG within 10 minutes and this thing. So if the patient is a candidate for ST elevation myocardial infarction, then the next guideline or the best method of treatment is a primary PCI. Now, primary PCI, if the patient presents to the hospital within 12 hours after symptom onset, then the next decision is, where does the patient present to? Is it a PCI capable hospital or a non-PCI capable hospital? So if he comes to a non-PCI capable hospital, the first thing the physician has to think is that once he diagnoses ST elevation myocardial infarction is, can this patient be referred to a PCI capable center, and can his angioplasty be done within 120 minutes? That is, within 2 hours, can he be shifted and will he undergo angioplasty? If the answer is yes, then definitely he should be shifted to a primary PCI center. But if the answer is no, that is, if he feels that the patient is in a remote area, he cannot shift the patient to that area within 2 hours, then the best treatment modality is to go for a reperfusion. That is fibrinolysis. And if the patient comes with an acute coronary syndrome and there is a cardiogenic shock or a hemodynamic instability, then even if the delay is more, it's actually, the recommendation is that it's better to shift the patient to a primary PCI center. This is mainly because the mortality rate is very high in spite of even if you fibrinolyze this patient. But if you feel that the distance is very far, patient is very hemodynamically unstable, he may not even reach that center, then fibrinolysis is still an option if the patient comes with a cardiology, but it is a last option. Now, if the patient comes with ST elevation MI to the hospital within 12 to 24 hours after symptom onset, again, primary PCI is the best treatment. Fibrinolysis is not considered as a treatment modality if he crosses 12 hours of ST elevation myocardial infarction. So less than 12 hours, fibrinolysis or primary PCI, but primary PCI first. If within 90 minutes, you can do it in a PCI hospital, or if you can transfer the patient to another hospital within 2 hours. So primary PCI is your guideline. But after 12 hours, if it's 12 to 24 hours, patient comes to use STEMI, it is always better to refer for a primary PCI rather than going for a thrombolysis. It's mainly because the success of thrombolysis is less once the delay goes more than 12 hours. And the complications like bleeding risk is more than the benefit of thrombolysis. But if the patient presents to you after 24 hours with an ST elevation myocardial infarction, only if the patient has an ongoing ischemia or arrhythmia or a heart failure, worsened heart failure, then there is a role for primary PCI. If this patient comes with an ST elevation myocardial infarction with a onset of pain more than 24 hours, patient is completely asymptomatic, without any evidence of any ischemia, angina, heart failure or arrhythmia, primary PCI actually lacks any benefit in such patients. So it is always a dilemma when these patients come to us, because many of them will say that I was feeling very fatigued or some chest pain 1 week back, and we take an ECG, it will be showing an evolved pattern. So these patients actually, if it's more than 24 hours, if the patient has no ongoing pain or heart failure or arrhythmia, there is actually no role for PCI, because many of these patients are prone for, when we open the vessel late, they are prone for complications such as ventricular septal rupture and free wall ruptures. So if these patients are actually followed up, and the guidelines say that they may be amenable to revascularization after a period of 4 weeks, that is 28 days. Now, if a patient comes with cardiac arrest, and it is always better to resuscitate the patient and transfer to a PCI capable center. And patient with a cardiac arrest and ST elevation myocardial infarction, definitely primary PCI is your first line of treatment. So once you resuscitate, you take an ECG, it shows an ST elevation, or patient comes with ST elevation, he goes for a cardiac arrest. Immediately, once you resuscitate, the ROSC is attained, he should be taken for a primary PCI. But the problem comes is when patient has an out of hospital arrest, resuscitated, and then shifted to your center for further treatment. If the patient is comatose, and if there is poor prognostic signs like resuscitation time of more than 30 minutes, no neurological signs are seen, always a discussion should be made with the patient and the bystanders regarding the benefit and risk, and then only the procedure should be done. If there are worse prognostic centers like myoclonus, and severe changes suggestive hypoxic encephalopathy, even the primary PCI may be deferred. In any patient who comes with a restricted cardiac arrest with a non-ST elevation myocardial infarction, immediate angiogram is not indicated at present, because many of time it actually worsens the situation, especially it produces renal failure and other things. So only if there is an ST elevation MI post cardiac arrest, there is an indication for an early angiogram. So again, the same thing. If the patient is awake after a cardiac arrest, immediately primary PCI. Patient comatose, STEMI, but favorable features such very short cycle of CPR and in-hospital arrest, etc. Always go for a primary PCI. Comatose, presence of STEMI, and unfavorable features like long CPR or out-of-hospital arrest, unwitnessed witness arrest. Always after individual assessment, after discussion with patients, bystander, then only take the patient. And if the patient is comatose, but there is no ST elevation, just a cardiac arrest with a troponin elevation, better to defer angiogram in the initial time. Now, once you've diagnosed an acute coronary syndrome, what are the drugs that we can give for reducing the angina? So, all which you may be knowing, nitroglycerin or sublingual or IV nitroglycerin at 10 microgram per minute can be given. Always have a caution that this is contraindicated if the patient has severe bradycardia, if the heart rate is less than 60, or patient has an RV myocardial infarction or a hypotension, because it can worsen the situation. The other drug that we normally use is morphine or fentanyl. Morphine at a dose of 2 to 4 mg, which can be repeated every 5 to 10 minutes up to 10 mg. Or fentanyl can be used, which now we normally prefer fentanyl more, with 50 microgram, because the amount of vomiting, etc. is less. But the most important point that you should remember is these drugs can delay the absorption of P2Y12 therapy, that is clopidogrel, etc. It can delay the effects of these drugs. So this may act as a factor causing acute stent thrombosis. So normally we give these therapies only if the patient is not responding to conventional therapies, or if immediate PCI is not getting available, or patient is not tolerating the pain. Otherwise, as soon as possible, we load the patient and send the patient to shift the patient to cath lab for a primary PCI, rather than a routine morphine or fentanyl is not administered nowadays. Now, oxygen therapy, as we all know, that normally we don't give oxygen unless the saturation is less than 90% or patient has features of heart failure. Routine oxygen therapy is not recommended. In the previous guidelines, you would have known, I think it is the 2014 guideline, they would have advised oxygen for at least 6 hours. But nowadays, the recent 2-3 guidelines, they have removed that. And oxygen therapy is only indicated if the patient has an oxygen saturation less than 90%. And regarding the antiplatelet therapy, aspirin, as we know, should be given oral loading dose, especially non-coated drugs. Actually, non-entry coated aspirin is the drug of choice. 325 milligram should be given. And along with that, the second drug, that is, we normally give either a P2Y12 inhibitor, which is either a clopidogrel, prasugrel, or a ticagrelor. Now, the decision of what to give is actually based on what you're going to do. If you're planning a primary PCI, if you're planning this patient has an ST elevation MI and you're going for a primary PCI, your drug of choice is prasugrel or ticagrelor. Reason being, they have the least stent thrombosis. If you're planning it's a ST elevation myocardial infarction, you're planning a fibrinolysis, then your drug of choice is only clopidogrel, because the least bleeding risk is with clopidogrel compared to prasugrel, ticagrelor, and clopidogrel. So if you're planning STEMI with fibrinolysis, your drug of choice is clopidogrel, and you have to load 300 milligram. But if you're planning a STEMI is going for a primary PCI, your drug of choice is prasugrel 60 mg or ticagrelor 180 mg. But prasugrel should not be given if the patient has any history of ischemic stroke or any hemorrhagic stroke at any time. And its dose should be reduced if the patient has a weight less than 60 kg or his age is more than 75 years. This is mainly because it has the highest bleeding risk. Now, if the patient is having a ST elevation MI, you're going for a primary PCI, and you feel that this patient is, normally we have this situation, the patient will be loaded with clopidogrel, comes to the hospital. So normally what we do is we load again a 300 mg. So if you see the loading dose of clopidogrel, it is 600 mg or 300 mg. So it is, we prefer 600 mg when we are planning to take this patient immediately for a procedure. This is mainly because, as we know, clopidogrel is a prodrug. It has multiple levels of action. it has, if you take the bioavailability, it goes to around 4 hours to 6 hours if 300 mg loading is given. But if you are able to load 600 mg, you can decrease the onset of action and get a half-life by around 3 to 4 hours. So only the first 3 hours, there is still a doubtful, the levels of clopidogrel may not be enough to prevent acute stent thrombosis. So that is the reason why ticagrelor and or prasugrel is a preferred choice compared to when compared to clopidogrel. But if you're going for a medical management with an acute coronary syndrome, a non-ST elevation, then the drug of choice is actually ticagrelor. It can be used in both ST elevation MI or non-ST elevation MI. So a P2Y12 inhibitor should be administered along with aspirin, and if the patient has history of stroke or TIA, prasugrel is contraindicated. And this is again the same protocol. If you're going for a PCI, whether it's in STEMI or a non-STEMI, your drug of choice is ticagrelor or prasugrel. Clopidogrel can be used if prasugrel is not available, ticagrelor is not available, or the patient has a high bleeding risk. Now, if the patient is going for a CABG also, we actually load with aspirin, clopidogrel before the angiogram. Once we find that patient is going for a triple vessel disease, going for an CABG, we stop the P2Y12 antagonist. If it is prasugrel, we actually have to wait for 7 days. If it is ticagrelor, we have to wait for 3 to 5 days. And if it is clopidogrel, at least 5 days. So this CABG will be done only after 5 days. This is mainly to reduce the risk. But if it is an urgent CABG, patient has ongoing pain, cardiogenic shock, then it can be done after 24 hours of any of these drugs. If you are not planning any invasive management, ticagrelor is a drug of choice. And if it is fibrinolysis, that is a treatment of choice, definitely clopidogrel is your drug of choice. And again, clopidogrel, if you see the dosage, if the patient's age is more than 75 years, you don't have to load the patient. You only have to give 75 mg. If the patient's age is less than 75 years, then 300 mg is the loading dose if it is thrombolysis. So the same thing is explained. So in any patients with STEMI managed with primary PCA, prasugrel or ticagrelor should be administered. And patient with STEMI managed with primary PCA, clopidogrel is recommended if prasugrel or ticagrelor are not available and cannot be tolerated or are contraindicated. And in patient with STEMI managed with fibrinolytic therapy, as I mentioned before, clopidogrel should be administered concurrently. Now, IV cangrelor, that is another newer drug which is available, which is a reversible P2Y12 antagonist, which can be given parenterally. So this drug is normally recommended when patients either, we are not sure whether they have been loaded outside. They suddenly come into, sometimes what happens, patient will be immediately shifted from casualty to the cath lab, and the loading dose will not have gone. So even if you give any of the drugs, it takes around 30 minutes for the onset of action. So the initial 30 minutes, there is always a risk of hyperacute stent thrombosis. So in those patients, we can use IV cangrelor, or any patient who has severe vomiting. So you have loaded the drugs, patient is keeping on vomiting. You are not sure how much drug has gone in or not. Then cangrelor has a role. Third, any patient who is having cardiogenic shock. So because in cardiogenic shock, as you know, because the perfusion is less, we don't know how much of the drug will be absorbed from the GIT. So in these drugs, in these patients, cangrelor can be used along with aspirin. And normally, cangrelor is given throughout the procedure. After the procedure, we continue for 2 hours. And at the end of the infusion, we convert to either ticagrelor or clopidogrel or prasugrel. GP2B3A actually at present has no role for a routine infusion. It can be used only during the angiogram if you feel there is a lot of thrombus or there is the flow is very slow. In such situation only we use GP2B or tirofiban or abscesibam. Otherwise routine use is not there. Now coming to parenteral anticoagulation, when we are planning a PCA, our drug of choice is heparin. Other drugs which can be used is bivalirudin, especially that is preferred when patient have a heparin-induced thrombocytopenia or patient comes with primary PCA with thrombocytopenia. It has the least chance of heparin-induced thrombocytopenia. So bivalirudin also can be used. But enoxaparin is also there, but which is not normally preferred. But fondaparinux should not be used in any patients who is going for a catheter or any PCA type of intervention. So if you're fibrinolyzing the patient, then what to do about the anticoagulation? Ideally, you can use heparin or any of the anticoagulation, but you normally prefer it for 8 days. That is during the stay in the hospital. Initially, for the 48 hours, you can actually give IV heparin infusion, and followed by which a low molecular weight heparin or a fondaparinose can be preferred. Now, this same thing I've explained before. When we are going for a CABG post-angiogram, clopidogrel, we normally elective CABG, we actually stop for 5 days, prasugrel 7 days, and if it is ticagrelor, we can do the procedure after 3 to 5 days. But if it's an urgent CABG, it should be done at least after 24 hours of the drug intake to reduce the bleeding risk. Now, coming to lipid management, we know that in every patient with acute coronary syndrome, whether it's in STEMI or a non-STEMI, a high-intensity statin is your drug of choice. So by the definition high intensity, we mean that there should be a reduction of more than 50% LDL reduction. And this can be attained by 2 statins. That is, one is rosuvastatin, 20 or 40 mg, or atorvastatin, 40 and 80 mg. So they should be given. If the patient is already on high dose statin and his LDL is more than 70 milligram, then we have to use the newer non-statin drugs like ezetimibe, bempedoic acid, inclisiran, evolocumab, etc. If the patient is coming with an ACS and his LDL is less than 70, but still, if that's a recurrent ACS, if it's a second episode of ACS, then we target an LDL less than 55. So in those patients, even if it's less than 70 but more than 55, we may have to use ezetimibe or the other non-statin drugs along with the high-dose statins. And in patients who are having statin intolerance, definitely we have to go for a non-statin drugs such as ezetimibe, bempedoic acid, inclisiran, evolocumab, etc. So the same thing has been explained in this flow chart. Either we can use a high intensity statin or a statin with ezetimibe combination for maximum reduction in LDL. And our target LDL is actually to keep it less than 55 milligram deciliter. If less than 70 but still more than 55, always go for a non-statin along with high-dose statin. Now coming for beta blocker, as we know, if there's no contraindication for beta blocker such as acute heart failure, patient has no AV block, the PR interval is not more than 240 milliseconds, no severe bradycardia and no active bronchospasm, definitely beta blocker should be used in all patients with ACS, especially within 24 hours. And AC inhibitors and ARB also can be used in all patients with ACS. But the more benefit is seen in patients who are having LV dysfunction, EF less than 40%, a large anterol MI patient, if he's a diabetic, then it has a more importance or reduces more mortality and morbidity. So again, just summarizing the recommendation for STEMI. Yeah. So if the patient has a cardiogenic shock, it is the primary priority should be emergency revascularization. So patient should be shifted to a center with PCA capability. If patient is come to a hospital with PCA capability within 90 minutes, otherwise transfer to hospital within 120 minutes. And more than 24 hours, if there is no indication like ischemia, arrhythmia or heart failure, better not to do. So next thing is, now we have identified the patient as STEMI. You are not able to transfer him. You thrombolized him. What to do next? According to the guidelines now is that it's better to shift the patient as soon as possible to a PCA capable center. And what will we do? Normally we have to assess whether the fibrinolysis is successful or not. So if the patient has continuing ongoing pain, if his hemodynamics worsens, if he has arrhythmia, or if he has an ST elevation, that is resolution of ST is less than 50% in anterior wall and less than 70% in inferior wall, it means he has a failed thrombolysis. So definitely he requires an immediate angiogram. Then this is known as a rescue primary PCI, rescue angioplasty, sorry. But if the thrombolysis is successful, and if you shift this patient to a PCI capable center, we actually wait for 2 hours, and after and within 24 hours, we can definitely go for an angiogram. Then this is known as a pharmaco-invasive PCI. there was an earlier method where you thrombolize the patient, immediately shift to the next hospital and do an angiogram immediately. Then it's called a facilitated PCA. But because the chances of bleeding is very high because of the thrombolytic agents which have been given, that procedure is not performed nowadays. So we always wait for at least 2 hours post thrombolysis to go for an angiogram if brought to the hospital, even if the lysis is successful. So if a patient comes with end STEMI, what do we do? We normally assess the patient and see whether he is very high risk, intermediate risk, or a low risk. So if the patient has features of cardiogenic shock, heart failure, severe ongoing angina, or hemodynamic instability, then we have to immediately take him for an angiogram within 2 hours. If the patient has dynamic ECG changes and very high troponin, or serial troponin goes very high, like 1000, then the next troponin is 10,000, definitely there's an indication for PCA within 24 hours. If the patient has an intermediate risk, that is the normal patients who comes with ECG change and no symptom, and the next troponin is actually coming down, then you can wait even up to 72 hours. So angiogram can be done before discharge. And if the patient does not have any angina, troponin is negative, which is like a unstable angina, you can either adopt 2 strategies: either go for an angiogram before discharge, or go for a non-invasive testing like stress test or a treadmill or a CT angiogram. And if any of these tests is positive, then go for an angiogram. That is a strategy that can be adopted in low risk in STEMI ACS, which is an unstable angina. Now, when you come to a cath lab, what are the recommendations to be done when you go for an revascularization agent? So now the recommendation is better to try for a radial approach when we go for a primary PCA. This is mainly because the femoral approach can produce a lot of vascular complications such as hematoma, bleeding, hypotension, etc. Radial approach, the bleeding risk is very less, so it actually improves the prognosis. And when we are going for a coronary stenting, if the stenting is a complex procedure, if we have to put a stent in the left main, it is always recommended, class 1 recommendation, to use imaging, which is intravascular imaging, IVUS or OCT during the angioplasty. And among patients with ST elevation myocardial infarction, routine thrombectomy is actually a class 3 recommendation. So normally before every primary PCA, the first step that we do after doing an angio, put a wire, put a thrombus aspiration and aspirate it. But nowadays, routine aspiration is not recommended. It's mainly because of the high risk of stroke which can occur when you do the thrombus aspiration. So we normally put a wire, we just daughter with a balloon, that is we push a balloon and just see whether there's any flow. If we get a flow, we then go for ballooning and then go to the next step, stenting. But if we do not get a flow even after daughtering of the balloon, we then go for a thrombus aspiration with a thrombus catheter. But routine aspiration is contraindicated. Now, if the patient comes with a STEMI with cardiogenic shock, definitely the first treatment is primary PCA. We go for a PCA, but we try to do only the infarct-related artery. We do not try to go for a complete revascularization, because if we are going for a complete revascularization, that can cause more death and renal failure. So the previous guideline used to say that if the patient is in cardiogenic shock, you can go for the complete revascularization. So the present guidelines say it's a class 3 recommendation. And if the patient is hemodynamically stable, what we do is we actually do the culprit artery. If it's an inferior MI, we do the RCA. But if the patient has an LAD or a circumflex, we actually refer the patient for a CABG at a later date. But if PCA is amenable, we can do the PCA either during the primary PCA or before discharge. Again, NSTEMI with multivessel disease, if the cardiogenic shock, definitely again either a PCA or a CABG of the culprit vessel is actually recommended. But if he's hemodynamically stable, we can actually either go for a multivessel PCA or a CABG as indicated. Now, for the electrical complications, any patient who has a ventricular tachycardia post myocardial infarction, initially first 48 hours management is only conservative management, that is either give antiarrhythmic agents, or because we always know that ischemia may be the major trigger for the ventricular arrhythmias. So if you are able to revascularize and correct the potassium, magnesium, give beta blockers, we may be able to tide over the situation. But if the patient has a ventricular arrhythmia which is persisting more than 48 hours, there is a role of ICD after 48 hours and before 40 days. why this is important is before the recommendation of ICD was actually only after 40 days of a myocardial infarction. Any patient who comes with a VT after 40 days of myocardial infarction means that it is coming from a scar and not due to ischemia. So there ICD is only recommended. So now there is a recommendation that even after 48 hours, if the patient is having VT, an ICD can be put in. And for bradyarrhythmias, any patient who has a persistent bradycardia, especially persistent type 2 Mobitz or a complete heart block, which is infrahesian, definitely there is an indication for permanent pacemaker. But otherwise, normally, as you know, complete heart block is seen with inferior MI, where the treatment is only wait and watch. But if the complete heart block is coming in a patient with anterior MI, definitely there is a role for permanent pacing in these patients, because there the heart block is due to fibrosis and not due to ischemia. And in hospital management, as we know, CICU, telemetry monitoring, and echo before discharge. And the another different recommendation here is that it is better to keep the HB more than 10 grams if the patient is having ACS. So before it was 9 grams. Now they are recommending that it is better to keep the HB more than 10 grams. And during discharge, all these lifestyle modification, the importance of medications, everything has to be explained to the patients. Proper communication should be given. And definitely there is a role for cardiac rehabilitation, where the patient is encouraged to do various exercises and if possible monitored. Otherwise, if a person can come home and show, that is also indicated. Now regarding what about the dual antiplatelet therapy? So default strategies, any patient who comes with ACS, whether it's a STEMI or a non-STEMI, he should be on dual antiplatelet therapy for 1 year, which can be an aspirin with any of the P2Y12 antagonists. But if the patient has a high bleeding risk, for example, an elderly patient who has hematuria post PCI or post this thing, or any patient who is a liver transplant patient or having a kidney disease or a liver disease, many times they are very high bleeding risk patients. So in them, what can be done? So present guidelines say that after 1 month, at least after 1 month, you can change to a single antiplatelet therapy. And what are the options? Either you can go for ticagrelor monotherapy, or you can go for aspirin monotherapy, or you can go for clopidogrel monotherapy. But the drug of choice is actually ticagrelor monotherapy. Now, if the patient is on triple therapy, that is, patient needs an anticoagulation. For example, if patient has an LV clot, or patient has a LA clot, or patient has an AF along with acute MI, then he may need 3 drugs, that is aspirin, P2Y12 antagonist, and an anticoagulant. There, the drug of choice of P2Y12 will be only clopidogrel, again because of the least bleeding risk. So you're combining with an anticoagulant. And after 1 month of triple therapy, you can change to either clopidogrel with an oral anticoagulant for the next 12 months. The same thing has been explained. And every 4 to 8 weeks, an LDL lipid profile has to be done, and you have to see whether your target of LDL less than 55 is attained or not. Otherwise, the drug. Now, another important recommendation which has come is a class 1 indication for influenza vaccination in all patients with ACS. This is based on some studies which they have found that there is a reduction in MACE and mortality in patients who are getting influenza vaccination. Thank you.
Should we have a question and answer session now, or let us pass on to the next, because both are related, and then we'll go afterwards?
Sir, actually, the criteria says that if the ST elevation is more than 1 millimeter in at least 2 consecutive leads, in all the leads except V1 to V3. So in all the leads except V1 to V3, we need an ST elevation more than 1 millimeter in 2 consecutive leads. But V1 to V3, because normally there is a small ST elevation seen, the criteria is based on whether the patient is a male and what is his age. If it's a male and the age is less than 40 years, it should be more than 2.5 millimeters. If it is a male and the age is more than 40 years, it should be 2 millimeters. And in any female, it is more than 1.5 millimeters in V1 to V3. Rest everywhere, more than 1 millimeter in 2 consecutive leads. Yes, sir. That's the problem. Even we are also loading with EcoSprint. But guidelines say that, as we know, the absorption rate is more from the sublingual.
Can we ask the patient to chew ecosprin?
Ideally, I know, but acosprin cannot be chewed
I
actually.
mean, we can crush it and give it to
Yeah, but ticagrelor we actually crush and give, or we ask them to chew. But aspirin we normally ask them to take in.
So one more thing, is there any role for BNP or anti-pro-BNP in MI?
Yes, sir. It actually helps in prognostication. If the BNP is high, means the patient has a worse prognosis. But otherwise, if it is STEMI, definitely the main thing is to open the vessel as soon as possible.